My name is Ronnie Fass, and I'm from Case Western Reserve University. We have a session today termed or named Unmet Needs in GERD Treatment, why you should consider Stretta in your clinical practice. There are going to be two presenters. Myself, I will start for the first 20-25 minutes, and then followed by Professor Jan Tack, who is a professor of medicine at the University of Hospital at the Catholic University in Leuven. So, first thing, I'd like to start with my presentation, and I'd like to start with an assumption. So the current assumption, the treatment in GERD, it's a general assumption. The treatment in GERD is predicated on the assumption that symptom improvement and healing of erosive esophagitis represent normalization of esophageal acid exposure. So that brings several points for discussion. The first one, do we need normalization of esophageal acid exposure to achieve symptom resolution in gastroesophageal reflux disease? The second question is, do we need complete healing of erosive esophagitis to achieve symptom resolution in gastroesophageal reflux disease? Is there an inherent discrepancy in GERD between subjective and objective clinical endpoints regardless of the therapeutic modality? And what is the evidence? So let's move on to the first assumption. In GERD patients, symptomatic response to PPI treatment requires normalization of esophageal acid exposure. And I'll show you some studies that actually clearly demonstrated that there's no really need for normalization of esophageal acid exposure in order to achieve a complete symptom resolution in patients with gastroesophageal reflux disease. So for example, this is a study, 5 patients, all of them had Barrett's esophagus. All patients had complete symptom resolution on 20 to 60 milligram a day of omeprazole, and you can see when they assessed them with a pH test, they found out that 80% of them had abnormal acid exposure. This is another interesting study. Again, these are Barrett's patients, admittedly, and in this study they looked at 30 Barrett's patients who were all treated with lansoprazole between 15 to 30 milligram a day. All patients had complete symptom resolution. And they found out that 12 of the patients had abnormal acid exposure while they were tested on treatment. Significant number of the patients. There was no difference between the groups in symptom frequency at baseline, in symptom severity at baseline, in the lansoprazole dose, length of Barrett's esophagus, hiatal hernia size, LES resting tone, or esophageal peristalsis. This is another study, again in Barrett's patients, looking at symptom resolution and esophageal acid exposure. This is a study that I've done a while ago. We looked at 25 Barrett's esophagus patients. They all received 40 milligram twice a day omeprazole. Now, of the 6 patients with abnormal pH test, 66.7% of them were asymptomatic. This is a study that actually looked at GERD patients. And you see here, they looked at GERD patients, and they were all asymptomatic on PPI treatment. And they found out that about half of them had some variable within their esophageal acid exposure assessment that was abnormal, and half of them had normal. So 50% of them demonstrated abnormal esophageal acid exposure. And when they looked, they found out that these abnormalities were noticed in the total time that the pH was less than 4, upright and supine time. 50% of the patients, they were all asymptomatic. This is a very interesting study. This study comes from from China, and they took 80 GERD patients, 76 of them had a positive pH test. They were treated with esomeprazole for a period of 4 weeks. And they looked at those that were symptom-free after this treatment, and they found out that about 90% of them had pH negative, but 10% of them, despite the fact that they were symptom-free, they had an abnormal pH test. Interestingly, when they looked at those that had persistence of symptoms on therapy, they found out that about 67% of them had a normal pH test. This is a study that actually was done by the surgeons, but they looked at PPI treatment in patients with gastroesophageal reflux disease. 30 patients all received PPI, and they evaluated them with a pH test. All were symptom-free, and in this study they found out that 60% of them had abnormal esophageal acid exposure. What about doing surgery on these patients? This is a study that came from the surgeons. They looked at Nissen fundoplication, 19 patients, and when they assessed them with acid exposure after all these patients were completely symptom-free, about 11% of them still had abnormal acid exposure. Now let's look at question number 2. Question number 2 is, in GERD patients, complete healing of erosive esophagitis is required for symptom resolution. This is actually a study that looked at patients with erosive esophagitis. All patients were treated with esomeprazole 40 milligram once a day, and patients were followed over a period of 4 weeks. At the end of 4 weeks, 82% of these patients demonstrated complete healing of their erosive esophagitis, but you can see that there is a discrepancy. The discrepancy was about 8% of them, so only 74% of them demonstrated complete symptom resolution, a discrepancy of about 8%. But Don Castell, who is sitting on the left side there, this is one of his studies, and he looked at patients that received, patients all with erosive esophagitis, randomized to esomeprazole 40 once a day or lansoprazole 30 milligram once a day, and he looked at healing versus symptom resolution. The discrepancy here goes up to 18%, unlike the previous study. Even though by day 8, 50% of the patients were symptom-free. Again, the studies continue to show the same thing, a discrepancy between symptom resolution and healing of erosive esophagitis that can reach, these are all patients with erosive esophagitis, that can reach 10 to 20% discrepancy rate. So what does it mean, what I just showed? So it means that many GERD patients with improvement or resolution of symptoms continue to have abnormal esophageal acid exposure. And that complete normalization of intraesophageal acid exposure is not necessary for symptom resolution. Now, the exact acid exposure threshold for symptom resolution is unknown. And there may not be a universal esophageal acid exposure threshold for symptom resolution. The esophageal acid exposure threshold for symptom resolution may differ among patients. What is the threshold for one patient may not be for another. And the esophageal acid exposure threshold for symptom resolution may vary in the same patient in different times. That complete esophageal mucosal healing is not required for symptom improvement or resolution. And the question is, at what point of esophageal healing symptoms start to improve or completely resolve is unknown. And that complete healing may not necessarily result in symptom resolution. So, this is a question as a paradigm shift. In therapeutic trials of GERD, regardless if medical, surgical, or endoscopic, symptoms should be the main clinical outcome. Complete esophageal healing of esophagitis is unnecessary for symptom resolution. Normalization of esophageal acid exposure is unnecessary for symptom resolution. So I'd like now to go and speak a little bit about a recent publication that we had that in surgical endoscopy. It's a systematic review and a meta-analysis that looked at controlled and prospective cohort efficacy studies of the endoscopic radiofrequency treatment, the Stretta procedure in patients with gastroesophageal reflux disease. The aim of that publication was to determine the efficacy of the Stretta for treatment of gastroesophageal reflux disease, and in this study we included, publication we included 28 studies with almost 2,500 patients. It included 4 randomized controlled trials, 23 prospective cohort studies, and 1 prospective registry. Now these are the clinical endpoints that were evaluated. There were subjective and objective clinical endpoints. These are the classic clinical endpoints that you see in endoscopic therapeutic trials. And they include the health-related quality of life, proton pump inhibitor use, esophageal acid exposure, heartburn score, erosive esophagitis healing, and then lower esophageal sphincter basal pressure. So this is the assessment of GERD symptom relief. When you look at the mean treatment effect, which is obviously the main outcome of these studies because it addresses symptoms, the mean treatment effect was similar between the RCTs and the cohorts, and the Stretta in this meta-analysis significantly improved symptoms as compared to Sham. When you look at heartburn score, there were 12 out of the 13 studies that showed significant treatment effect, a significant reduction in patient heartburn score. When you look at the erosive esophagitis, these studies looked at changes in fraction of patients with any erosive esophagitis between baseline and follow-up, so post-procedure. And there was a 36% reduction, complete healing of erosive esophagitis as compared to baseline from this meta-analysis. When you look at PPI use, 23 studies were evaluated, 1,795 patients. 97% of the patients were on PPI at baseline. And there was a 51% reduction in the number of patients that were still using PPIs as compared to baseline. And this is during a follow-up of between 3 to 120 months. When you look at the esophageal acid exposure, there was a significant improvement in the Dept score, as you can see here, and 30% of the patients normalized after the procedure. When you look at the LES resting pressure, 9 studies evaluated that with about 269 patients. And while the studies did show increase in the LES baseline resting pressure post-procedure, it did not reach statistical significance. So if we look overall, kind of get overview of the results of this meta-analysis, we can see that in relation to acid exposure time, there was 32% improvement. In relation to erosive esophagitis incidence, 36% resolution. In case of heartburn score, 58.2%. In relation to a health-related quality of life score, 60.2% improvement. And in relation to patient using PPI, 51% reduction. Now, when you look at adverse events in the Stretta versus Sham, and in some of the study, the comparison of the Stretta was to Nissen fundoplication, laparoscopic fundoplication, you can find that the percentage of side effects or adverse events was 0.93%. And you can see the number of patients that didn't have it, as compared, for example, to the laparoscopic fundoplication to about 7.2%. And if you look at the Stretta, most of the side effects were really minimal and included small mucosal erosions, where in the case of laparoscopic fundoplication, there were a variety of complications, including some of them that were devastating. So I'd like to conclude here in relation to our meta-analysis. So the meta-analysis demonstrated that the Stretta procedure significantly improved subjective and objective clinical endpoints. The subjective clinical endpoints include health-related quality of life and heartburn score, and the objective clinical endpoints included esophagitis incidence, use of proton pump inhibitors, and esophageal acid exposure, and that the procedure was very well tolerated with minimal adverse events. This is, by the way, my take on the Chicago classification. This is the Chicago hot dog classification version 4. Thank you. Okay, I'd like to invite Professor Jan Tack.
So I'm from Leuven, Belgium, and we looked at Stretta very early in its existence already and tried to explain a couple of things on how it might work then. If you get very good symptom control, you have significant effects, but relatively smaller effects on acid exposure. Can we explain this? So these are some disclosures. So PPI is a starter and you double the dose, and those who do not improve, if you can establish that reflux are the symptom, is driving the symptoms, you go for surgery or other anti-reflux surgery, anti-reflux therapy. And Stretta is one of the earliest endoscopic procedures presented. And the idea behind Stretta is that you deliver radiofrequency at the junction in a short, very well controlled and well tolerated procedure, can be done under conscious sedation. And over time, you would get a remodeling of the sphincter, a kind of pressurization. Now, worries are that this is perhaps fibrosis, and this is perhaps not what we want. So that is one worry. Second worry is I'll show you two different meta-analyses prior to Ronnie's, which come to very different conclusions. So this is a meta-analysis which was published in Clinical Gastroenterology Hepatology. And they included only 4 studies and looked at the outcome on acid exposure and said we don't have a significant outcome on acid exposure. Looked at LES pressure, said we don't have a significant improvement in LES pressure. Looked in these same studies, 3 of these 4, at ability to stop PPIs, there was a significant outcome, and looked at health-related quality of life of PPIs, and there was significant benefit. But the conclusion of this study was it's not effective because pH monitoring is not improved. Then there was a SAGES meta-analysis, including many, many more studies, looking at symptom parameters, subjective measures, finding robust signs of improvement on all of these. Looking at esophageal acid exposure, finding robust improvement in acid exposure, the Meester score, and looking at LES pressure and finding a significant improvement there. And actually in this meta-analysis, they said we have more than 30 peer-reviewed studies, including 4 randomized controlled studies, meta-analysis, prospective trials, case series, and they actually conclude that this is appropriate therapy to use for GERD patients over the age of 18 who have symptoms of heartburn, regurgitation for 6 months or more, and partially or completely responsive to PPI therapy. And it had a very strong recommendation and a high grade in evaluation of the quality of evidence. So what to make of that? So we started some data and some data collection at our center, and I will show you what we did. And we did actually 3 levels of studies. We did a single center case series, but there's many of these in the literature. We did some mechanistic evaluations to explain, is there anything beyond acid exposure? And we did, as part of that, a single center, sham-controlled mechanistic and efficacy trial. So who was allowed to undergo Stretta procedure at our center? Those, as in the SAGES meta-analysis and review, aged above 18 years, evidence of reflux disease, so pathological acid exposure of PPIs, and persistent, preferably typical. We allowed very few patients with atypical symptoms under PPI treatment or with intolerance for PPI or a desire to stop the PPI. All of them had to have at least a partial response to the PPI. Exclusion criteria were high-grade erosive esophagitis, big hernias, and long segment, more than 3 centimeters, of Barrett's esophagus. And so in total, we, at the point of this analysis, we had treated 85 patients, a majority female, 49 and 36 males, mean age, end of the 40s, 49 years old, and a reflux disease history of 6 years. We did all the procedures under conscious sedation except 4 patients who preferred general anesthesia. And conscious sedation was 6.3 milligrams of midazolam and 70 milligrams of petidine on average. Tolerance, complications, very little problems. Incomplete procedure because of lack of cooperation under conscious sedations, people who became restless where we stopped. Technical procedure problems, some difficulty with deployment of the needles in 3 out of these 85. 15 of the 85 patients had mild transient retrosternal pain, usually 1 or 2 days. We had 1 where it went up to 3 weeks. Hemorrhage mild, 2 patients not requiring any intervention, no repeat endoscopy also, and transient fever in 1 patient. And then this open label cohort, we had a combined reflux score that we followed, and of PPI, we started at 15 on PPI, this dropped to 12, and then at 3, 6, 12, and 60 months of follow-up, there was a significant and well-persistent decrease in reflux severity score. So at least if you look at the open case series over time, we have a robust and persistent beneficial effect. PPI use dropped coincidentally to about 50% of the patients, whereas before more than 90% were on a PPI, some of them because of intolerance used H2 blockers or nothing. But at 12 months, we are having a few patients, 25% on double dose PPI, small 20% on single dose, and that's it. So a very significant shift in PPI use at 1 year follow-up. So this actually shows in our hands this is easy to do, safe, and effective. What about mechanism? What did we look at? We looked at LES pressure, and at 6 months, this is what was our evaluation point, resting LES pressure is not significantly altered. Not a lot is happening there in our hands. pH monitoring, however, we see over time an improvement. We start with on average 15% of acid exposure over time. At 6 months, this is dropped to about 12%. This is not significant. But if we do the 12-month evaluation, we get a significant benefit, and pH exposure has now dropped to about 7%. So there seems to be a later catch-up of acid exposure improvement, and I think this is consistent with the modality. So one thing that had been suggested, if you have we have at 6 months significant symptomatic benefit, no significant improvement of pH at that time, no rise in LES pressure, what happens to sensitivity? And so in a cohort of patients, we did acid exposure during acid perfusion and looked at time to induce heartburn. And prior to the procedure, this was 9 minutes. And 6 months after Stretta procedure, this was 17 minutes. This caused a lot of noise because people said, you're making the esophagus hyposensitive, you're eliminating nerves, and perhaps this is not what we want to do. Well, let's look a little bit closer at these data. What is happening is that the majority of patients have some improvement. There are a few in whom acid sensitivity is not changed, and we have a small cohort of 4 patients who become asymptomatic during up to 30 minutes acid exposure, acid perfusion. Is this correlated to the acid exposure time? And actually, if you look at the Meester score, this is not correlated to sensitivity. But the symptom severity score upon the questionnaire is correlated to acid exposure. So I think the change in acid exposure drives the symptom improvement in this cohort, and it's not a change in sensitivity. And in the vast majority of patients, this is a small change in sensitivity. So if anything, it's change in acid exposure already that early on that is driving the symptom evaluation. So the other thing we thought of is perhaps there's something else happening. We have a decrease in acid exposure, but this takes a little bit longer. We have a decrease in sensitivity to acid, but this does not drive symptom response. And with pH monitoring, you know that acid is coming up how much of the time, but you don't have a clue about the quantity of acid coming in. And if this is increasing the LES muscle volume, actually you could envision that reflux is not cut out completely, but the amount of reflux volume that comes up during transient LES relaxation, for instance, could be a lot less. So we thought we should look at distensibility of the junction and resistance to reflux volume coming up. And we embedded this as a single center, sham-controlled efficacy and mechanistic trial focusing on LES resistance. And you need to give something to the patient, so we put this in a crossover design. And you know, the data in the literature were at 6 months, but we chose to go to 3 months to motivate patients to participate. So we could say to the patients, if you participate, at 3 months everybody will have had active treatment. And there was a blinded evaluation because the physician who did the treatment, active, Stretta or Sham, was not the same person who was evaluating at follow-up visits symptom benefit. And so people were randomized to a first active and then second sham procedure, or vice versa, with a 3-month interval, and those who had the sham procedure then received active treatment. And we followed symptoms and pH monitoring and LES distensibility. I'll show you how we did that. And we randomized and included 22 patients. Small cohort. At first glance, perhaps not powered enough to look really at symptoms, but the mechanistic evaluation was the bulk for us. And we used the same inclusion criteria as I showed you before. So at baseline, both groups were well matched looking at the GERD symptom severity score that we used. And at 3 months, in the sham group, where we just did a conscious, deeply sedated endoscopy, moved in the Stretta catheter, blew up the balloon, but they don't deploy the needles. We did not administer any radiofrequency energy. There was no significant benefit. But in the active group, there was a drop to about 65% of the composite GERD score that we looked at. And then this group, when followed up, showed some further improvement at 6 months. The sham group was crossed over, and at 3 months, they actually caught up with the initial active group. So in spite of the small size in this crossover design, single center study, we have significant benefit on symptoms with the active, not the sham procedure, and after we cross over, they pick up. We looked at acid exposure, and on the left you see the group who received Stretta procedure first, and at 3 months there's no significant effect. At 6 months there is a tendency for decreased acid exposure as a median, doesn't reach significance. And in the sham first group and Stretta afterwards at 3 and 6 months, there's no significant benefit. So we have symptom improvement, no change in acid exposure expressed as percentage of time that there's acid in the esophagus at the same time points. And what we did antedated the use and availability of the endoflip for distensibility studies. So we used the poor man's device, a self-made big barostat bag that we straddled across the junction under fluoroscopy, and we progressively increased the pressure in the balloon, and we measured the volume. And we validated by doing simultaneous fluoroscopy and measuring it that the volume in the balloon was driven by the diameter at the junction. And when the junction opened, this is when the balloon volume accumulated. Poor man's low-tech endoflip-like procedure, but it worked in our hands. Of course, the worry is, it is said you have tissue remodeling and you want muscular hypertrophy, you don't want fibrosis. And we thought, let's use a drug that is good for everything to evaluate whether there is fibrosis. What is a drug that is good for everything? Sildenafil. It's a recreational drug in some people's hands. But actually we had published a study that sildenafil, acutely administered, wipes out LES pressure. It wipes out contractility in the distal esophagus. It's a smooth muscle relaxant. So we were actually going to use administration of sildenafil to unmask any effect on LES resistance that is fibrosis, that is not driven by muscular contractility. So this is the validation study. We have the images below, not so easy to see, but we measured the diameter here, and this is the increasing balloon pressure. And you look at the volume before and after administration of sildenafil in healthy volunteers. And for the same pressure, you get a bigger volume in the balloon, so you relax the junction. And so this is the protocol: isobaric distension, sildenafil administered 50 milligrams directly intragastrically, and then 20 minutes later we repeat the distensibility. And now this was done in the trial before and after active, or before and after the sham procedure. So this is the sham procedure, and we're showing in solid lines the pre-treatment control, and in dotted lines the pre-treatment after sildenafil, and you get the relaxation from baseline to sildenafil. And after the Stretta, after the sham procedure, 3 months after, actually the lines are again well superimposed. So the sham procedure doesn't change this sensibility. Very different for the active procedure. This is the baseline before, and this is after the active Stretta procedure. You get much lower volume, so there's a big resistance at the junction. And the pre-treatment sildenafil and post-treatment sildenafil are superimposed, so there's no fibrosis. This is muscular hypertony that we wipe out with sildenafil. So after sildenafil, the tensification of the junction, the resistance to distension, is gone. And if we put this in numbers, this is before sham and Stretta. This is 3 months after sham and Stretta. A significant decrease in compliance, a stiffening of the junction, but then if we give sildenafil before the procedures or after, all are at the same level. So this is a muscular hypercontractility driven by the procedure, not by sham, and released by sildenafil. So this sham-controlled single-center mechanistic study shows that the mechanism may involve increased muscular tone at the junction, and this leads in our hands to efficacy in controlling symptoms, and perhaps this increased resistance makes that the volume that comes up during reflux is a lot less, and thereby cutting symptom expression of reflux events. So to summarize this, Stretta procedure is effective in sham-controlled studies for symptom control in GERD. It's a safe procedure in skilled hands. Mechanism of action is not driven by the change in sensitivity, the improvement. It may relate to decreased GE junction distensibility and decreased refluxate volume. And this decreased GE junction distensibility is not attributable to fibrosis. And it is effective for typical partially PPI responsive GERD or patients who want to stop the PPI. And I think ongoing studies are needed in difficult patient groups, after surgeries, bariatric and so on, and this is ongoing. Thank you for your attention.